It's Michelle and Kayla again to talk about the second tab in the fall incident report, which is injuries. So not all residents who fall are going to have injuries. Some residents just bumped onto the floor, you got them up and everything was fine, and you'll need to leave this blank. But if there's a skin tear or a bruise or redness or a laceration, whatever it is, it needs to be documented in the injuries. Or if there are multiple injuries, you can document as many as there are. So first you're going to pick the location. It's not going to be ideal. It's just kind of a general location. And then the type of injury, again, it might not be exactly what occurred, but we find whatever's closest. And you'll put a detailed description in the note area of exactly what the injury was.
So if I have a resident that I find 5 different bruises or 2 bruises and a laceration, do I just keep hitting the new button?
Yep, for every bruise and every laceration, just to make sure every injury is noted. So next you're going to come down to the pain scale. It's really important to be identifying the patient's pain at the time of the fall. So this is the initial pain assessment. So he might have been a 4 out of 10 at the time of fall, pretty manageable, didn't even want Tylenol for it. We're going to go down and we're going to look at the resident's level of consciousness and mental status. This could, likely they're alert and they got back up. They also could be completely unresponsive and you've called 911 and sent them to the hospital. Maybe they're just a little bit drowsy. You're also going to want to document the orientation of the patient, and this is going to be at the time of the fall, not their baseline mental status. You will need to note if it's different than their baseline, but this is at the time of the fall. The mobility section is their mobility prior to the fall. Were they a freely ambulatory patient? Are they wheelchair bound but tried to stand up? And then in the note, you're going to put very detailed descriptions of the injuries. So where the skin tear is, what it looks like, what the measurements are, what you treated it with, what the peri wound looks like, where the bruises are, general shape, size, color, that kind of information. You always want to be, whether it's at the end of your shift or the next shift or the next nurse, documenting follow-up pain levels. There's going to be follow-up injuries to document too. We don't always notice bruising at the initial fall. Maybe 2 days later, they've developed 5 large bruises right in the area where your very detailed description told me they hit the ground. So we know that those bruises were related to that fall. The pain assessment at the end of your shift or the beginning of the next nurse's shift is going to be really important to identify if there's any trauma that we didn't note at the time of the fall. We had a resident who fell and had no pain during the fall, got into bed and was fine, and the next morning had really bad hip pain and it was x-rayed and he had a fracture. So the pain is not always going to be instant. If you think about when you fall at home, you get up and you're embarrassed and it sucked, and tomorrow your leg is killing you. So it's really good to identify that this increase in pain was related to the previous fall and a clear description of their mentation following that. Are they now more confused? Did they maybe strike their head and we didn't know about it?
I would also say a lot of you are probably thinking, well, how am I going to know if I need to go back in and document on this incident report? Well, the person who shift this patient was injured will have put them on alert, and so that would let me know if I see that they're on alert for a fall, anything during my 8-hour, 12-hour shift that could possibly be related to the fall they had, then I know I need to go back in and maybe add some additional information into the incident report.
This is a huge document. It's not always just completed by one nurse. The next nurse is going to add details. The nurse manager and the director of nursing are going to add details. So a lot of information will be gathered after the fact.